Hello, my name is Mackenzie Danker, and I am an FNP student at Saginaw Valley State University, and I will be presenting a presentation on patient falls for my class Nursing 760, Nursing Informatics and Quality Improvement. Patient falls are among many of the nurse-sensitive indicators for quality of nursing care in the National Database of Nursing Quality Indicators, and they are actually one of the most prevalent adverse events that occur in the hospital setting, so much so that 700,000 to 1 million inpatient falls occur every year in the United States hospital system, and current research reveals that almost 1/3 of those events are preventable. When fall incidences do occur, they can cause serious physical injury and sometimes even death to patients, in addition to financial burdens on them as well. That can be far more than what the patient may have otherwise had to deal with while being in the hospital. And overall, this can affect their quality of life due to these additional medical expenses. They end up staying in the hospital longer, and then obviously the discomfort and injuries that can come with falling. Patient falls also affect the hospital system itself, mostly financial strain that can be due to the longer patient stays, medical care costs that are associated with the fall, and then legal actions that can be taken against them because of the fall. Hospitals don't receive reimbursement for any injuries that are related to falls because they're considered a never event. Therefore, prevention of these events is of very high priority to the hospitals. And they can also contribute to decreased patient satisfaction scores and just an overall poor reputation of a healthcare system if they have very high inpatient fall rates. Patient falls are an outcome measure that is reflective of the quality of nursing care that's provided to patients. And nurses hold that responsibility of providing direct care to patients while preventing any potential harm or adverse outcomes of the care that they're providing. And because the nursing profession has the foundational principle and responsibility of bettering the quality of the nursing practice that we provide, it's imperative that we find evidence-based solutions to be able to decrease the incidence of patient falls in the hospital. And because it is within the nursing profession's scope of practice to be able to utilize and follow the nursing process of assessing, diagnosing, planning, implementing, and evaluating patients, we're able to rely on our autonomy and judgment to be able to initiate individualized fall prevention plans for patients in order to provide safer and higher quality of care. There are many contributing factors to patient falls, including advancing age, specifically 65 years and older, having multiple comorbidities, the use of certain medications and multiple medications, specifically psychotropic and antihypertensive medications, having cognitive impairment and delirium, a previous history of falls, visual impairment, gait instability, and muscle weakness, all encompassed in the physical environment that people are in, all contribute to a patient's fall risk. So therefore, because there is such a large range of factors that can cause a person to fall, it is imperative that we're performing accurate risk assessments on these patients to be able to implement effective strategies and interventions in order to prevent them. However, current evidence has focused mostly fall prevention strategies in community and residential care facility settings rather than in the hospital setting, so evidence currently provides limited support as to which approaches are the most effective in preventing patient falls. However, there was a qualitative study done by Gettens and his colleagues in 2018 that studied patient perceptions regarding fall prevention interventions, and it showed that many patients in the hospital hold this false sense of security because they believe that the environmental design of the hospital and having clinicians present will protect them from falling. And unfortunately, It's not uncommon for them to then use their own judgment despite their actual level of capability, and then they engage in fall risk type behaviors such as not using their call bell before getting out of bed, and then they attempt to ambulate or mobilize without waiting for assistance. And this can obviously be problematic and dangerous for those that are at risk for falling. So patient education is one important strategy to incorporate into care that can help patients be able to self-manage their risk. Also, a scoping review that was done by Hang and his colleagues in 2020 suggests that a well-designed patient education program should be in place to help increase knowledge and fall risk awareness and help empower patients to be able to play a role in prevention measures and also comply with prevention interventions that are already in place. There's a variety of levels of evidence that suggest different types of patient education related to fall prevention, like printed handouts, videotapes, posters, communication alerts like bed alarms and sensors, having face-to-face discussions about anti-slip footwear, using the call bell, and some other specific patient interventions. And in order to better promote compliance with these fall prevention initiatives, that study encouraged staff modeling of safe behaviors along with giving reminders and advice regarding the fall prevention measures that are individualized for each patient. There was also a systematic review done by Juan and his colleagues in 2016 that focused on prevention of falls in hospital settings and found that one of the most important aspects of a fall reducing intervention program was a patient risk assessment. It was one of the most significant aspects because it allowed hospitals to be able to efficiently use its resources and also devote specific attention to those that were at very high risk for falling. One of the most widely utilized scales in the clinical setting that's been shown to be effective in measuring the risk for falls is the Morse Fall Scale, what we're all probably familiar with. It's easy to administer, it's a simple instrument, and it is able to assess the risk for which a patient could fall by evaluating their history of falling, any number of additional diagnoses that they may have, if they're able to mobilize without assistance, if IVs or other devices are involved, what their current gait is, and mental status. The scale then will calculate a score and determine if a patient is in a low, medium, or high risk category, and then from there, specific interventions can be implemented based on what category that patient is grouped into. In the current evidence, there is a large amount of variability in what interventions have been shown to be the most effective in fall prevention programs. However, the evidence that has the highest level can help guide what strategies would be most successful. And in that systematic review that we just talked about, Juan and his colleagues suggest that the use of assistive devices should be used if appropriate, such as walkers and canes. Instructing patients to use their call bell and wait for assistance, and providing non-slip footwear, in addition to some environmental modifications like keeping the room well lit and free of obstacles. It's good to provide care in areas where support items are easily and readily within reach, like side rails and handholds, and also keeping the height of the bed low and other furniture in an easy accessible position. The study also supports the use of patient and family education in order to encourage patients to be actively engaged in fall prevention, and also engaging in physical fitness and therapy in order to prevent falls, because a lot of patients will develop muscle atrophy when in the hospital for a long time, which in turn will decrease their stability with mobilization and increase their risk for falling. There's also an older systematic review that was done by Miyake Lai and his colleagues in 2013 that recommended the use of bedside risk signs, wristband alerts, a supervised toileting schedule, and medication reviews in addition to all of those previously stated recommendations. In 2020, there was an evidence-based, nurse-led, patient-centered fall prevention program called the Fall Tailoring Interventions for Patient Safety, or TIPS, toolkit that was designed in order to enhance patient and family engagement in fall prevention measures. This toolkit utilizes health information technology in the form of an EHR-generated poster or an electronic bedside screen display that'll automatically update in real time from data in the EHR. And it uses the Morse Fall scale to link certain risk factors with specific preventative interventions, and then the intervention will provide patients, families, and any interdisciplinary teams that work with the patient with the patient's specific fall risk factors, individualized prevention interventions, and also some education. And in this non-randomized controlled trial testing of this toolkit, there was a statistically significant 15% decrease in total inpatient falls and a 34% decrease in falls that caused injury. At the macro system level, reviews of best practices and mistakes should be determined and evaluated by the hospital system at regular intervals in order to identify and assess the risk of certain events that can trigger falls, and also analyze the actions that are being taken to lessen this risk. Also, post-fall analyses should be done in order to reduce fall rates because they can help identify factors that led to the fall, and then preventative action can be put into place in the form of policies in order to prevent these future events from happening. Hospital systems must also provide training and tools to the staff because they're at the forefront of preventing falls of patients. So by instituting these training procedures regarding quality and safety, in addition to forming standard policies and procedures to care for high-risk patients, best practices are able to be implemented and risk factors can then be addressed within the institution. Research has also found that high leadership support from hospital directors, for example, is essential in implementing effective fall prevention programs. For example, in the study that was done regarding the TIPS toolkit, leadership at the institutional level was needed to be able to support that interventional program. At the microsystem level, nurses need to be involved because of their ability to perform evaluations and assessments. They're able to help develop new methods that will improve patient safety despite standard operating procedures and training. And just like at the macro system level, there also needs to be some unit level leadership support, such as a unit director, in order to be effective at implementing fall prevention programs. At the unit level, people like nurse advisors are able to help determine adherence to these interventions through patient engagement audits and questionnaires, and then feedback from unit level nurse advisors can then be passed on to the higher level leadership roles in order to evaluate and address the pros and cons of these interventions. Also, while the nurse advisor can give feedback at the unit level to the nurses that are caring for these audited patients. So just a quick overview of this presentation. Patient falls are related to a wide range of risk factors, such as age, having multiple comorbidities, and then just being in an unfamiliar fall-prone environment. Patient falls can cause serious injury and harm, and sometimes even death to a patient. And they're also just very costly for the patient and the hospital system altogether. And we can measure a patient's fall risk using the Morse Fall scale, and current evidence believes that the use of multiple intervention techniques should be used in order to have effective fall prevention initiatives. And also having support and involvement at the macro system and microsystem level is essential in order to have effective fall prevention programs for the safety of patients. And here is a list of my references. Thank you for listening.